Special advocacy grand rounds near us to November 20th. That's the National and International Day of the Child, celebrating the adoption of the Convention on the Rights of the Child by the UN General Assembly in 1989. And today it is my great privilege to introduce my good friend and colleague, Dr. Jeff Goldhagen, child health advocate extraordinaire. He's Professor of Pediatrics and Chief of the Division of Community and Societal Pediatrics at the University of Florida, Jacksonville, and President of ISOP, the International Society of Social Pediatrics and Child Health. He has provided leadership nationally in the United States in the development of comprehensive public health systems and systems of care for children's medical and behavioral health. As the president of ISOP, Dr. Goldhagen is currently working with a global consortium of professionals and organizations to advance the health and well-being of children, including addressing issues of violence against children, migration, climate change, etc. And I guarantee a stimulating and informative presentation this morning. Welcome and bienvenue, Dr. Goldhagen.
Great.
Take it away.
Great. Well, I can't tell you how much I appreciate the opportunity and privilege to be with you this morning. I know those of you who know Sue and have worked with Sue know her to be an amazing asset, not only for you all in Canada and Ontario, but for all of us globally. Her work with ISPCAN and ISOP, her work with the general comment to the Convention of the Rights of the Child. She's made a huge impact. And I've really valued her, not only her friendship, but her colleagueship over the years. So what we're going to do today is really take a journey. It's going to be, I think, a bit different from most of your grand rounds. It's not so much of a focus on walking away with any particular facts, but really an opportunity to take a step back and relook and reframe how we think about pediatrics, how we think about children, how we think about childhood. So it's a journey that I hope you'll enjoy, and we'll go ahead and get started. I've now routinely started with this picture. I don't think that any of us anymore, in particular in pediatrics, can hide from the fact that we now are responsible for the existential threats that climate change and the environmental changes have on us, and in particular on children, and the Iroquois maxim of thinking in terms of generations in the future as it relates to actions that we take today, I think could not be more germane. So years ago, I did a grand rounds, presentation, which I can't find, which was looking at the history of pediatrics through art. And so we're going to start off with just a few pictures here that really reflect how far in many ways that we've come over the years, thousands of years for sure, starting back with Egypt and pictographs from Egypt, and then moving more than 1,000 years to Rembrandt's classic picture of the anatomy lesson, and then moving forward another close to 500 plus years to Norman Rockwell, and looking at where we were only 100 years ago in the practice of pediatrics. Many of you, most of you know Norman Rockwell. His work as an illustrator on the Saturday Evening Post was iconic. And here we have the depiction of cutting edge pediatrics in the 1920s. And as you can see, the pediatrician at most has his technology relates to listening to this doll's heart. So that was a reflection of really where we were in medicine, in pediatrics less than 100 years ago. And if we move forward from the 1920s into the 1950s, we now are at a place that, in fact, technology, as represented by vaccines and immunizations and the shot in 1958 and the thermometer in 1954, we've moved from this paradigm for the practice of pediatrics to this paradigm for the practice of pediatrics really in only 25 years. So the velocity of advances in pediatrics and medicine is happening really very, very quickly. And then if you go to today, right, if you go from this 1950s, move ahead another 50, 60 years, this is where we're at today. And what I find really fascinating, if you go onto Google images and put in modern medicine, all you get is pills. That's all you get. There's no pictures of MRI machines or other types of surgical robots or any other equipment or any other technology. What you get is pills. And so in a sense now, we've moved from here to here. And this represents, at least to Google, who's the master for all of us in many respects, this represents modern medicine. But what we're going to focus on today is not modern medicine, but the chasm between modern medicine and the chasm between that evolution of pediatrics, as we've seen in the pictures, to really what are the issues impacting children's health and well-being. And so this chasm is reflected in the difference between the depiction of modern medicine and the realities of the children that children are experiencing and facing globally. And whether it's the issues related to violence and the impact of armed conflict, or starvation, or child soldiers, or the impact of what's happening in the Middle East, in Syria and Afghanistan and Yemen, the impact of war and violence on children, and the disabilities that it causes, and of course what's happening here at the southern border. It's shameful, and particularly shameful to be an American where this is happening today. And we just had a paper. We have a paper being published in pediatrics. It's going to appear in January, but because of the timeliness of what's happening at the southern border and the policy of the American policy to move these children without parents, without any support, back into Mexico and so on, we're defining this as torture. And so the paper that will appear in January is really redefining what we see, whether it's kids along the southern border or children in Afghanistan, wherever, that the impact of the violence that's being perpetrated against them rises to the level of torture. And so the root causes for these issues clearly is not the acute lack of medication and pills, but what's happening all around us. And in the one of the key messages that hopefully people will take away from this presentation is that pediatricians and pediatrics has a critical role to play in addressing these issues. So certainly globalization is having a fundamental impact on children's health and well-being through the effects on climate change, globalization, war, violence, and so on. and climate change, which is unquestionably the existential threat affecting all of us, whether it's in high, middle, or low-income countries, and clearly for children and youth, representing an existential threat to their future. So globalization and climate change are critical issues that are fundamentally changing the ecology of children and childhood. And if we really take a look at the root causes of these global childhood morbidities and inequities, we can divide them up. Certainly there are others, but war and violence and the impact of armed conflict on children is fundamentally impacting children all over the world, and you know, certainly in the Middle East and Africa, now raising its ugly head in South America, and the issue of violence in the in the communities in the U.S. So none of us are really immune to the effects of violence on children. Migration and refugees, children on the move. Today, there are 65 million refugees around the world, more than after World War II. About 40% or more are children. And so today, as we sit here today, the effects of children on the move is greater today than it ever has been, at least since World War II. Poverty, malnutrition, emerging infections, and the environment. So when we take a step back and really look at what are the critical issues, what are the root cause issues impacting children and childhood globally and in our own countries as well, these are the root causes, and again, not the acute lack of medication. And we know that healthcare contributes about 10 to 15% to health outcomes, and these issues are the ones that are impacting the other 80% of health outcomes. And so what I want to move to next is really looking at this from an historical perspective. And what they're going to present is not a revolutionary change in pediatrics and the practice of medicine that was reflected in the pictures that I started with, but really an evolutionary process that brings us here today. And unfortunately, most of us don't really have an understanding of the history of medicine, but in particular the history of pediatrics. And I'm certainly not a medical historian by any means, but it does provide a depth of understanding and appreciation. And as my title to the presentation say, you don't know where you're going until you know where you've been. It's critically important to look historically as to the evolution of pediatrics and medicine in general to really have an understanding of where we've been and where we're going. And so I'm going to take a few minutes. This is a huge, very complicated slide that diagram I put together a number of years ago, but I want to spend some time dissecting this. And this is obviously framed in the context of the development of pediatrics in the US, but I suspect that it has as much relevance to Canada as it does to the United States. And if we go back and really look at the what I would call the beginning of contemporary pediatrics. I take it back to the 1950s. That's when we had the implementation of antibiotics and vaccines, modern day formulas, and so on and so forth. And so that's really when when I would say contemporary pediatrics begins, and we begin to talk in terms of general pediatrics. Thinking in terms of biomedical diseases that we can now address, like infectious diseases and nutrition. And the focus of that during that period of time is on the individual child. And that was really the beginning in the 50s of academic pediatrics, academic outpatient community pediatrics. And as you see, as we move forward here, that this history happens in 20-year intervals. So by the 1970s, something is transforming pediatrics, and it may seem so self-obvious and ridiculous to us today. But that really was the beginning when people started thinking about psychosocial pediatrics, the issues related to family, and that it was not just about medicine and medical issues, but also about psychosocial issues as well. So psychosocial issues and what I call psychosocial pediatrics began. Alpert and Charney in the U.S. published a paper for HRSA, which is our Federal Health Resources and Service Administration, and really began this movement toward understanding pediatrics and as something more than just a medical discipline. We started adding psychosocial issues. We started talking about behavior and development and adolescent health and prevention. And then we move over into the 1990s. And some of you may know Bob Haggerty, may have worked with him. Bob was a luminary in pediatrics here in the US, was president of the Academy, president of the IPA, and really fundamentally changed in many ways how we think about pediatrics. And he introduced the concept of community pediatrics. And as you see, as we move forward through this evolution, we don't lose what happened previously. We add it to the inventory of what pediatrics is about. And so we now add the community. So we go from the clinical focus to the psychosocial focus, and now to the community focus, and begin to think about other things within pediatrics. Issues related to environment, mental health, school health, drugs, alcohol, STDs, and so on. So we've now added the community influence. And then 20 years later, we begin to think in terms of society and the changing of the century. We begin to talk about move from the new morbidities, which is a term that Bob Haggerty had introduced in dealing with these kind of vulnerable populations, to now the millennial morbidities, which are grounded in social, economic, civil, political, and environmental issues. And so this 20-year intervals brings us back from really introducing antibiotics and vaccines to really now thinking in terms of globalization, impact of society on children, community, and so on and so forth. And this is when we begin to think in terms of the root cause determinants of health, and begin to think in terms of the social impact and impact of society on health. And so this is not a revolutionary process. This is very much of an evolutionary process. And if we look also on the impact on medical education, we started off with the academic outpatient department. Then we moved in the 1970s to think in terms of training residents actually in the community, and then added some service experiential learning to our medical education processes. And now we're talking about equity and social justice and advocacy and public policy in the context of training our residents. And so this focus in medical education really reflects the evolution of what's happened in pediatrics. And then if we take a look at the science, right, the science that really was supporting this evolution, we started back in the 50s and the epidemiology of infectious diseases and nutrition and vaccine preventable diseases and so on. The participants in medicine and pediatrics were primarily physicians and nurses. And then in the 60s and 70s, we began with the work of Michael Marmot to address issues related to the social determinants of health, and really reflected in the context of social epidemiology. And as you can see, and we'll talk a bit about these in a moment, but the participants in the care of children in pediatrics moves from physicians and nurses to subspecialists. We begin to add child development and behaviorists, and when we get to where we are today, now we've expanded it greatly. And so, the term that it takes a village to raise a child, Now we have the village really participating in pediatrics, not only in the medical area, but we have community leaders and agencies and child advocacy groups and pediatric organizations. And with the globalization of health, and we now have not only dealing with issues, and certainly COVID there's no better example of that, not only issues on our regional, local, regional, and national levels, but also international and global issues and participants in the care of children. So we've come a long way, really, in 50 years. And again, not in a revolutionary perspective, but really an evolutionary one. And so when we take a step back and really look at where we are today, really it's our understanding of social epidemiology that fundamentally has changed how we think about the issues that are impacting children. Now, in our division, we have residents. We have all the residents in their first year rotate through our division for a month on advocacy and community pediatrics. And over the years, including till today, I've asked every one of them how much time that was spent in medical school on addressing social epidemiology. And I have yet to find one. Maybe it's different in Canada, although we do have students, residents come here from Canada. There's almost, despite 50, 60 years now of our understanding of social epidemiology and our understanding of how fundamentally it's impacted our practice and our understanding of morbidities and mortality of children globally, it's still not a fundamental part of training in medical school. And so what have we learned? Well, we've learned from Marmot about the social gradient, and that it matters what you do and where you live. We've learned certainly about the impact of adverse childhood experiences, not only on children, but in the life course of all of us, including critically what happens in adulthood. We've learned a lot about disparities and the impact of place on health. And this is a startling look at female life expectancy at birth in the US based on where you happen to live. As you can see, I live right here. Florida is really transected here. This functions like our northern neighbors who come here to live. And then where I live, this is really still a part of the deep South. We know that it's not just about poverty, but it's income inequality. That really defines virtually every health metric that we can examine. So it's not just poverty, and it's not whether you live in a poor country or a rich country. It's how inequitable the resources are distributed in the country. We've learned about the immigrant effect. In the U.S., if you're a African woman coming to the United States, your birth outcomes are going to track exactly like wealthy white women. The longer you stay here in the United States, your birth outcomes are going to deteriorate. And if you're a rich, wealthy, African-American, educated African-American woman, your birth outcomes are going to be very similar to the African woman after she's been here for years. And so poor white women have far better birth outcomes than rich African-American women have. And obviously because of issues related to racism in the United States. And to support the social epidemiology, first we had the epidemiology, now we have the science behind it. And so we are well on our way to really understanding the reasons why there are such significant disparities in outcomes based on race, based on gender, and so on and so forth. We know that there's issues related to stress and the impact of stress, maternal stress on the fetus. We know there's impact of stress and corticotropin releasing hormone. We know that obesity is defined by birth, and your risk for becoming obese later in life is already defined at birth. And we no longer really talk about genetics. We talk about epigenetics, which is the impact of the environment on the expression of genes. And so we have the social epidemiology, we have the epigenetics, and I would suggest that the next evolving model, or the next part of the evolution of pediatrics, is really at the intersection of biology and social determinants and environmental determinants. Whether you call it, we call it here in my division, community and societal pediatrics. Around the world, it's mostly defined as social pediatrics. There's now a renewed interest in global health, moving from international health to global health. Sue and I and a few people around around the world are working on really defining a new context for pediatrics called planetary pediatrics, which not only deals with the issues related to children, but also the health of the planet as a critical integration of what needs to happen in the future to address critical issues for children. And then the movement towards One Health, which looks at not only the health of people, but the health of animals and the health of planets, and blending them into one integrated discipline called One Health. And so, so this is what we're inheriting today. And the diagram that I presented earlier needs to be updated to really look at these issues, because it's no longer about just focusing as far as participants on humans. We need the involvement of veterinarians and ecological biologists and so on and so forth as participants. And so if you take a step back, what are the social environmental determinants of children's health and well-being today? Well, it's certainly, if you look at regional and national perspectives, it's racism, it's discrimination, it's ethnicity, it's the impact of social and civil, political, and economic and cultural definitions, our understanding now of insults to brain development, so in particular early brain development, access to medical mental health services. And in the past we've talked about vulnerable children, but Sue and I have a close friend and colleague named Raul Mercer. Some of you may know him. He's from Argentina, and Raul has said, it's not about vulnerable children, it's about vulnerated children. That children aren't vulnerable by definition, they're vulnerated, and it's the impact of society on children that creates vulnerable children. And so I've started using the term that he's coined, which is vulnerated children, and it's certainly the built environment. When we go globally, we're dealing with climate change and environmental degradation and globalization, finance and trade policies, obviously war, armed conflict, migration, emerging infections, zoonoses that are impacting us, and clearly COVID is a great example. So these are the determinants of child health, not the acute lack of medicine. And so if we're going to make a difference, it's not just community pediatricians, it's all of us working in these domains if we're going to have the impact that we all seek for our kids. Now, Canada isn't immune to these issues, right? So in 2018, UNICEF published its ongoing look at the health status of children in high-income countries. Canada's 15 out of 29 in material well-being, 14 of 29 in education, behaviors and risks are 16, housing and environment are 11 out of 29. And when you look at health and safety, you're not at the middle, but move toward the end. So Canada is sort of stuck in the middle. There's lots of opportunities for improvement, and your children, in particular, your First Nations communities, are experiencing the same issues that we're experiencing in low-income and minority communities here in the U.S. And this is really interesting. In that same report, Canada's rankings dropped 7 places to 24 out of 29 countries when looking at children's views of their life satisfaction, right? And with looking at their perspectives on relationships with parents and peers, they're 25 out of 28 in industrialized countries. So the issues that we're talking about here today are germane in Canada as they are elsewhere in the world. And so I want to move now to introduce the next sort of iteration in this evolution. You know, we've talked in the past about epidemics. Now we're talking about pandemics, and certainly the new understanding of why epidemics and pandemics happen is being consolidated under the term syndemics, or syndemic theory. And basically, syndemic theory is really a reflection of our advancing understanding of the social determinants of health, which is that and epidemics, pandemics are not isolated, that they're impacted by synergistically by other issues that are happening, other morbidities that are happening around the world and communities, and that they combine in ways that we had not thought about them in the past. And so COVID as an example, I mean, if we want to take a look at COVID, we've defined it as a pandemic, but there's lots of people and lots of literature now that are reflecting that, in fact, it's moved from a pandemic to a syndemic, impacted by all of the issues that the social and environmental issues that define the health and well-being of individuals and populations. And so what we're learning from COVID is COVID, as many people are saying, is serving as a lens to magnify the inequities and disparities that have existed pre-COVID, but are now being exaggerated by it. So now we're going to move quickly to solutions, right? You know, from our perspective, from many of our perspective, that the only solution to addressing these social and environmental issues, the only solution that can provide a holistic approach to addressing the morbidities and mortalities that are happening around the world, including in our own countries, is by taking a child rights-based approach to addressing health and well-being of children. And I'm sure all of you are aware the Convention on the Rights of the Child has around 40 or so substantive articles that if you haven't read through the convention, I would ask you to do your homework and take a half an hour out of your busy day this evening and sit down and actually read through the convention and get an understanding of how fundamentally insightful it is. It has divided up into multiple different rights: economic, cultural, social, protective, and civil political rights. And there are some key principles. The two most important principles, I think, are the fact that rights are universal and follow the child. So children don't have rights by virtue of the fact of they live in a particular country, that their rights are universal. They follow the child, they go with the child, which has a really significant relevance to kids on the move globally. And that all rights are independent and indivisible, that if you want to fulfill the right of child to education or to healthcare, or to have a voice and to be listened to, you have to fulfill the rights of that child to the other 39 fundamental rights. And so the convention and a child rights-based approach really is the fundamental foundation for a whole child or a holistic approach to children and childhood. And And several years ago, actually 10 years ago now, a group of us had a policy statement published in pediatrics that really provided what a framework, so to speak, for translating the principles, standards, and norms of child rights actually into practice. And we said there are 4 elements to this practice of rights and equity, one of which is child rights, social justice, what we called human capital investment, and health equity ethics. The definition of equity is our systematic differences in health that can be changed. So we're not all equal, and I'm never going to be an Olympian shot putter. But what context of equity does provide us is an understanding that we all need the optimal opportunities to fulfill our future. So equity, human rights, social justice, how we distribute limited resources. These are the key elements of a child rights-based approach to addressing children's health and well-being. And then we talk in terms of human capital investment, that really, if we're going to succeed in addressing the issues of children in childhood, we need to be investing in them. And if you take, we talk in terms of 5 different contexts for human capital investment: social, economic, environmental, educational, and personal. And if you take the rights that are in the Convention on the Rights of the Child, and divide them up into these 5 forms of social capital, really what we're doing when we're investing in the human capital of children is we are addressing and fulfilling their rights. And so there is and we don't have time to talk about it today, but there is a way of translating this child rights-based approach to the work that we do as pediatricians and child health providers. Now, those of you who follow this work know that the world had focused on the Millennium Development Goals from 2000 to 2015. Interestingly enough, there were 8 of them, and many of those goals were fulfilled. And then in 2015, we launched the Sustainable Development Goals, of which there are 17, of which most of them actually have a focus on children in childhood. And so the context that we need to be moving forward in is an understanding of framing our work in rights and the sustainable development goals. And so if we take a step back, excuse me, and look at what an agenda for societal pediatrics or global pediatrics or planetary pediatrics, whatever term you want to give them, is beginning to link our beloved profession to the Convention on the Rights of the Child, to the principles, standards, and norms of human rights and the Sustainable Development Goals. And a few years ago, we have a statement that was published on our website, and the ISEP website, which I'll mention in a moment, really looking at what is this agenda. And we spent about a year working with pediatricians, social pediatricians around the world to really define this agenda. And this is just a summary. It's detailed in much more depth on our website. But these are the issues we think we need to be using to frame our work. First is lack of secure places, and the impact of poverty, discrimination, and social exclusion, the effects of the social and environmental determinants of health, addressing the increasing medical complexity, in particular as we've gotten better at curing disease and or preventing morbidities and mortalities from disease. We've developed a whole cadre of children that are living with disabilities and complexities that we never dealt with before. So addressing the medical complexity and disabilities of children globally, changing family structures, and then the effects of marketing and consumer society. We are getting here now to many of the societal issues, the consequences of globalization, environmental changes, and really beginning to think in terms of all policy being health policy and being in particular child health policy. What you see on the side here is how each of these issues are reflected in the context of the articles of the convention and in the SDGs. So whether it's secure places or poverty or exclusion, family structure, and so on and so forth, the articles of the convention address all of these. And as I mentioned, as one of the critical principles, they can't be divided. None of them have a hierarchy, that all of them need to be addressed and dealt with in the context of the work that we do in pediatrics, if in fact we're to achieve the outcome that we all seek for kids, which is optimal health and well-being. And so I want to end here. It does leave us some time for questions and discussion and perspectives. I'd like to hear from you very much. And so if we had to ask the question, where are we going next in pediatrics, and where are we going next as communities, or where are we going next as a population of humans in the world? And I would say this is where we're going next in pediatrics, that we have the opportunity, the responsibility, and if we don't take it now, then it won't exist for our children to really address the critical issues that are impacting the health and well-being of children, not only in our communities and our regions and countries, but also globally. So I'm going to stop here and say thanks. But before I do that, I'd like to project here a shameless advertisement for ISOP. So ISOP is the International Society for Social Pediatrics and Child Health. We've been around for 40 plus years, initially as the European Society for Social Pediatrics. Now, over the last 10 years, changed to the International Society for Social Pediatrics. We are arguably the only global social pediatrics organization that exists. Our focus is on addressing not only the biomedical issues, but the issues that are impacting children that we spoke about today. Over the last several years, we've had a focus on the impact of armed conflict on children. And we're moving to, over the next several years, to focus on climate change. And frankly, we need your involvement, we need your help, we need your support, we need your leadership, we need your brains, your thinking, your experience, really, in order to be able to succeed in what we're attempting to do, which is optimize children's health and well-being wherever they live. We have a child rights framework. All of our work is done in the context of child rights. We work extensively with other organizations like IPSCAN, UNICEF, WHO, many NGOs, World Vision, Save the Children, War Child, and so on and so forth. So I'd ask you to take a few minutes of your day or evening, go online, look at our website, take a look at many of our statements and work that we're doing. We have an initiative now focused on the impact of COVID. We have over 100 people, researchers, colleagues from around the world that are working in 7 or 8 different thematic areas related to COVID. And we love your involvement and your expertise. So I'm going to stop here. I know we've come a long way from the Egyptians to planetary health, and appreciate your patience and time.
So thank you very much, Dr. Goldhagen, for an outstanding talk. Um, I think it's, we have to say it's embarrassing for us in Canada to find where we sit in the recent UNICEF scorecard. And I just wonder where, in terms of strategies that you would recommend for us as a community of pediatricians, what it is we should be doing to influence government and other agencies around trying to affect the slide that has occurred over the last number of years in relation to that particular scorecard.
Well, that's a really great question. If you go back, UNICEF, the Innocente Center, does this scorecard every 2, 3, 4 years. The previous one had Canada a little higher. The US shared the last place with UK. And we weren't even close to the next country, which was Portugal at the time. For in the U.S., we ranted and raved and yelled and screamed. Nobody was interested at all in the fact that we were last. In the U.K., actually, they paid a lot of attention to it, and there was a lot of response to it, and a lot of embarrassment, and a lot of input into investment in children. And so it can have an impact. And I would say the first step is marketing. Frankly, the first step is really making sure that communities know, that local governments know, that national governments know, and to go back and really look at the root causes of what these issues are. And it's investment not in the medical aspects of children's health and well-being, but in the social determinants of children's health and well-being. And going back to the basics of the convention. First being that hearing the voice of children, making sure that in fact their voice is heard, that it's not us as duty bearers that are representing these issues and reflecting these issues, but it's children and youth themselves as rights owners that are bearing the taking much of the responsibility to ensure that communities know where we are and what is impacting them. So I would say first and foremost, hearing the voice of children, allowing them to take the lead in addressing the issues.
Okay, thank you. We have a question from GB. I'm not sure who that is. I guess we don't. Erica.
Yes, can you hear me okay?
Yes.
Thank you. I wanted to thank you for this very thoughtful and insightful talk. A lot of things to think about and remind us to keep in mind as we practice. I also wondered about your thoughts on how this explosion in digital health and technology might be potentially increasing the health inequity as we're not only practicing now with these new technologies, but our practice of medicine in general and pediatrics is being defined and evolving based on machine learning and technologies that I do think have a significant potential to worsen these healthcare disparities.
Well, so it's interesting you asked the question. The way the convention, the way the Committee on the Rights of the Child addresses issues related to the convention is like a constitution. It's hard, or it's not actually changeable, but there are amendments in a sense to the convention, and they come in the form general comments. And the general comment that's out there now is focused on something a little bit different, but I think is related to this, which is the digital world that children and youth are living in. So on one hand, we think in terms of the effects of COVID and our movement into the virtual world as negative as it relates to our practice of pediatrics. But if you assume that the practice of pediatrics contributes about 10 to 20% to health outcomes, then it leaves the other 80% to think about how, in fact, this movement to the virtual world, the movement to social media, all of these other aspects that we're being caught up in can, in fact, be reframed and recontextualized to actually be a benefit for children. And so in the same way now that Zoom allows us to communicate in ways that we had the opportunity to do so in the past, but never really did, it also opens up the opportunity for children around the world to communicate, to magnify their voice, to influence one another, and so on. So my feeling is that we're just beginning to understand the power of technology to really improve health and well-being, in part by amplifying the voices of children and youth that have not had access, in particular to lead decision makers as they've had in the past. It has some negative aspects to it, but clearly there's some potential opportunities as well.
Daniel, you've got a question.
Yeah, thank you, Dr. Duffy. I'm one of the fourth year pediatric residents here at CHEO, so thanks, Dr. Golden, for the wonderful talk this morning. Dr. Goldhagen, I had a question. Well, actually, first a reflection. So one of the things you mentioned near the beginning was how, while the discussion of social determinants of health dates back a couple of decades, it's only more recently that we have started as a profession to look at more structural determinants, policies, and things like that, in addition to the more intermediate determinants such as food security, poverty, income inequality. And when I reflect on my own medical education in medical school, that was very much the case too. A lot of education surrounding things like income and food security and poverty, but not very much about the policies and the politics that shape those economic and social determinants. And I think historically as a profession, physicians have often been reluctant to address political realities. Sometimes physicians have been branded as unprofessional for taking too much of an activist stance. And yet you cannot address all these intermediate factors and influence the lives of our patients without addressing the wider social structural causes that are creating these inequities or maintaining them. For example, in Canada, there have been quite large discussions recently in public discussions surrounding a basic income, for example, and universal pharmacare, both of which influence so many of the intermediate determinants that we deal with on a daily basis. So how do we increase the comfort and increase the acceptability within our profession to take a more activist stand and to shift into the mainstream the capacity to influence or to want to influence public policy?
Well, that's a great question. And so I think it's a simple triangle. And at the bottom of the triangle is clinical. In the middle of the triangle is systems. And at the top of the triangle is public policy. And what I would say, and what we teach our residents, is that in fact, we shouldn't have the privilege of calling ourselves pediatricians until we're skilled at all three levels. And it doesn't necessarily mean that every pediatrician is going to be a policy wonk and work significant amount of the time in public policy, but understanding the critical roles that public policy has. And so, it's true, it's been true through the years, what gets tested is important. And so as we look at redefining medical education and residency education to have a focus at those three levels, and to begin to redefine what it means to be a pediatrician as a person that is skilled in the clinical work, understands how systems impact children's health and well-being, and the critical need for public policies that support those systems. And until we're there, then I don't think we'll achieve what we want to achieve. And and then I think it's not. Well, I'm going to just say it. I mean, we, meaning people my age, are leaving a terrible legacy for people who've come after us. And as we talk in our rotation, you get to make the changes, right? You get to make history. You get to change it. And if not you, then it's not going to happen. And you'll be here 40, 50 years. We won't, but you will, asking the same, and people will be asking the same question. So it's, and there's no risk to it, right? So pediatrics, medicine in general, pediatrics in particular, there's no risk for being courageous. If in fact you fail, there's always a job for you. There's always some place for you to be. And so this is you have a privilege to be able to be courageous in addressing these issues in ways that other colleagues don't, and in many ways, and in ways that we haven't.
Thanks.
Other questions or comments?
That's why I only get invited to talk one time at places.
Yeah.
I don't get a lot of invitations to come back, but
Well, it's interesting. Just to Daniel's point, at least there is some movement in certain quarters. Child Healthcare Canada, which is represents academic health centers for pediatric institutions across the country, is driving an initiative to really push and force issues at a government level, with many opportunities to link in with politicians and not only with MPs but also with senators to educate them somewhat with regards to certain aspects of things pertaining to child health. And it's gathered some momentum, and so we do hope that will have some impact. One particular aspect revolves around the whole issue of a child health commissioner, which had been introduced in the UK, and so we are hopeful that will come to pass, but it has stalled somewhat.
Yeah, well, we look to you to enlighten us in the U.S. in many ways. And I don't think we can escape the fact that we're torturing children by public policy at the southern border of the United States. And that's something we can't overlook. And it's a role that not only pediatricians in the academy and so on here in the U.S. can take a position on, but also Canadian colleagues, Canadian organizations. ISOP has taken a position on it. And so we need to take a step back and really look at these critical issues. We have a paper that's being published was just accepted, being published in pediatrics by a Canadian pediatrician named Tom Adamowicz, who's working now in Atlanta on bombing children. Right? It's our bombs and our military that are supplying and supporting Saudi Arabia in what's as one place, and what's happening in Yemen. That's a critical role. I mean, that's a critical issue for us as pediatricians, whether we're subspecialists or community pediatricians or whatever, that needs to be addressed. And our voice, frankly, isn't heard. And so shame on us, but it does provide us an opportunity to really rethink our roles and responsibilities, not only nationally, Canada, the US, but also globally.
Thank you. Any further questions or comments? Sue, do you have any closing remarks that you would wish to make? I guess not. So we'll close it there and say thank you very much, Dr. Goldhagen, for an excellent presentation. You've certainly highlighted certainly. So I think Sue is coming on board.
Sorry, I'm just trying to unmute myself. Thank you so much, Jeff. You brought so much today in enlightening us all on the very existential issues that are facing us personally and professionally. And I just want to say warmly, thank you so much, a merci. And we all need to be, as you've given us, a very positive asset, strength-based, talk about opportunities and possibilities. We can easily go to the dark side, and we need to retain our own spirits, humanity and spirits and mental health to be able to be the greatest advocates that we need to be for kids.
Right.
So,
well, again, I need to thank you all for the opportunity, and and Sue, thank you for all the work you're doing there, but also globally. And please join us in this up. We're now divided up into regions, and Sarah Gander is taking a lead in Canada. And so we need your involvement, we need your support and leadership, and we're not gonna get to where we need to go ourselves. It's gonna have to be together. So appreciate it.
So we'll draw it to a close. Thank you very, very much, and good luck with your work.
Thank you. Take care. Bye-bye.